Through the state's recent fiscal crisis, funding for many DPH programs was either reduced or eliminated. Many of the programs subject to these reductions are listed in the agenda. We note that while it's encouraging that we are recovering from the recession and that our revenue picture is brighter, we would still recommend a cautious approach to restoring funding that balances paying down the debt and putting funds in the rainy day fund in order to maintain flexibility in funding current programs in the case of an economic downturn.
Okay. Any other comments? Okay, we have a panel of Erin Fox, who is the Director of State Health Equity and Public Policy, LA's Gay and Lesbian Center, Highland Annex. Is he here? Erin Fox. Good. Eileen Espejo is here, the Director of Media and Health Policy, Children Now. Rodelia Kilson, who is from the Sacramento County Black Infant Health Program. Matthew Marsom, Vice President for Public Policy and Programs, Public Health Institute. Bruce Palmer, Executive Director, Health Officers Association of California. Rusty Salek, who is the Executive Director of California Council of Community Mental Health Agencies, and Laura Thomas. Laura Thomas is here. Got to find another chair. Okay. Laura Thomas, who is the Deputy State Director of Drug Policy Alliance. Okay. She gets a big chair. Okay. Okay. I want to thank you all for coming here today to present before the committee. I'm going to ask you, if you can, to try to keep your comments down to about 3 minutes each, since we have a good-sized panel, and that will give the legislators, the committee members, opportunity to ask questions, as well as our Public Health and Office of Finance and LAO to respond to any issues we may want to respond to as well. So we're going to begin with Erin Fox.
Thank you, Madam Chair. And I think I'm on the right issue this time. Since the beginning of the HIV/AIDS epidemic, California has been a leader in supporting public health initiatives that both prevented new HIV infections and provided people living with HIV the medical care that they need and deserve. In 2006, total, California allocated approximately $180 million to HIV programs, including testing, housing assistance, education and prevention, and the AIDS Drug Assistance Program, and more. And then in 2009, approximately $86 million of this funding was blue-penciled by Governor Schwarzenegger, wiping out all HIV prevention funding. And as we sit here today, the California General Fund contribution to achieving an AIDS-free generation is zero. With the second largest disease burden in the United States, California must reinvest public health dollars for effective, scientifically proven interventions to help end this epidemic once and for all. A recent CDC study found that the 2009 California cuts to HIV prevention over 4 years resulted in approximately 1,400 fewer diagnosed infections, 32,000 fewer people having received risk reduction services, and most alarming, 220 new infections generating almost $80 million in lifetime treatment costs alone. These cuts did not ultimately save the state any money and have only resulted in greater need for public health investment. Since 2009, science and the epidemic have changed. We now believe that we have the tools to end this epidemic in the United States. The Obama administration has released the National HIV/AIDS Strategy, and along with implementation of the Affordable Care Act, we believe that with the proper resources dedicated to the proper communities, that we can effectively end HIV as we know it. One of these tools is PrEP, pre-exposure prophylaxis, which the FDA recently approved. It's a daily pill that people can take in order to prevent them from contracting HIV. When this pill is taken on a regular basis and clients adhere to it, it is extremely effective at preventing HIV, and this is one of the game changers that has happened since 2009. And we believe that public health reinvestment in educating communities, especially communities that are hardest hit by HIV, particularly young African American and Latino men who are gay and bisexual in urban areas, desperately need access to new prevention interventions. And there is a significant lack of education right now and lack of understanding around this specific tool. And if we are going to refocus our efforts on prevention, this is one place that we can refocus and where California can take a leadership role again.
Okay. Eileen?
Thank you, Madam Chair and members of the subcommittee. I'm very pleased to be here today to ask you for your help to restore funding to the California Children's Dental Disease Prevention Program and for a statewide dental director. Dental disease, more specifically tooth decay, is the most chronic health problem among children in California and one of the top reasons why they miss school. In 2007, more than 500,000 of California's school-aged children missed at least one day due to a dental problem, a total of 874,000 missed school days, amounting to an average loss of nearly $30 million in attendance-based school district funding. The California Children's Dental Disease Prevention Program, CCDDPP, was highly successful in helping to improve the oral health of California's underserved. Until its suspension in 2009, the program had provided evidence-based oral health prevention services, such as fluoride varnishes and sealants, to hundreds of thousands of children preschool through 6th grade right in their own school. Schools with at least 50% free or reduced school lunch eligibility throughout 32 counties. Further, CCDDPP provided case management for children needing extra help with urgent needs and ensured that these children received further treatment. The program also aimed to address two critical issues. It saves the state money, and it can strengthen the state's public health system. In saving California money, the prevention of tooth decay works on several levels: the health of the child, relief to the parent, and savings to the taxpayer. Aside from keeping children in school to learn, the program also leveraged additional dollars. During its last year of operation, local programs leveraged over $2 million, mostly through in-kind volunteers, rent, equipment, and other resources. For every dollar spent on prevention, up to $50 are saved in more costly restorative treatment. These savings could lead to additional savings to Medi-Cal and lessen the burden on other providers to perform these services. Preventive services, such as those offered by the program, also help to keep children out of emergency rooms, freeing up valuable time and resources. Finally, regarding the state's public health system, the state has had to forego valuable resources to its public health infrastructure as a result of losing the program. The program had provided the infrastructure and capacity to assess the true dental needs of California's children statewide. For several years now, the state's been unable to provide accurate data on the true numbers of children suffering from preventable dental disease. Federal money that could improve the infrastructure of the public health system has been given to other states that have a school-based sealant program. So certainly restoring CCDDPP would make California more competitive in getting federal dollars. In my remaining seconds, I wanted to close by outlining the need for a statewide dental director. California needs someone to increase the visibility and improve the coordination of work on oral health issues. Their leadership would help to establish and oversee the implementation of a statewide oral health plan, monitoring and evaluation of treatment, and help bring to scale the best practices of prevention programs, such as the core components of CCDDPP throughout the state. As mentioned, the state has not done well taking advantage of federal and private monies that are available for dental programs, something that a dental director could do to help identify and apply for such grants. So as this committee considers how to reinvest in the state's public health infrastructure, we would urge you to secure funding for this position. Thank you.
Thank you. Ms. Rodela Kilson?
Yes, ma'am, Madam Chairperson. Honored to be here to support and represent the Black Infant Health Program on today. As a first-time mother, I sought out more education and informed information on how to not only have a healthy pregnancy, but how to deliver a healthy baby at full term, and to further ensure that I, as a Black woman, would be the same healthy and informed. And if we could all refer to the summary that was just so eloquently put together there, I just wanted to make out a couple of points. First of all, starting out with in 2011, stating that the preterm birth rate for Black mothers was 13.5%, and that is compared to not only the state preterm birth rate of 9.8%, but in comparison to other cultures, this number was significantly higher of the babies that were not born at full term. As we all know, healthy habits are produced over a course of time, and healthy habits lead to the most positive outcomes possible. In the 10-week program that Black Infant Health program puts together, they review all types of topics, including stress, how to become a better leader in your community, healthy habits with eating and exercise, and how to be empowered as a leader in your community and as a Black woman. Not only does this help us individually, but it helps us to create more structured families, be stronger and more committed individuals in everything that we do. They offer a healthy lunch, they offer bus fare, they offer gas cards and incentives for attending on time. Also, I wanted to point out in the summary as listed above, the Black Infant Health Program provides healthy education and social support over the course of the 10-week program for prenatal mothers and a 10-week program for postnatal mothers. They partner with different social organizations such as Birth and Beyond, Jack and Jill's Incorporated of America, and sororities such as Sigma Gamma Rho. The excellent facilitators and staff of the county also do follow-ups with each of the mothers on a weekly, bi-weekly, and monthly basis, which not only builds a rapport with the staff, but allows us to become more comfortable with them and to feel like we have an additional support system outside of the families that we may or may not have. I just wanted to share today as a personal experience that I believe that myself and my child would not be where we are today if it were not for programs such as this. I would definitely refer it to others, and going forward, I would hope that this is something that would continue to be supported, not only on a city and county level, but on a statewide and national, and hopefully one day international level. Thank you for your time.
Thank you. Mr. Matthew Marsom.
Thank you. Good afternoon, Madam Chair, members of the committee. Matthew Marsom with Public Health Institute, and I'm pleased to have the opportunity to speak to the committee today about this critical opportunity to make necessary investments in California's public health infrastructure. Today, we sit at a critical juncture in the field of public health, with new and emerging public health challenges such as climate change, as well as the persistent challenges we have heard about already today from the panel. These threaten not just individuals and families, but the well-being and economic vitality of our entire state. These challenges are compounded by the funding cuts over the last decade in the State General Fund, but at the same time, there has been little or no investment at all of State General Fund in community prevention programs to address the burden of chronic disease in California. Now, I'm sure we're all proud in California of the leadership our state has shown in the implementation of the Affordable Care Act. We at PHI feel strongly that our state has an opportunity to lead in true health reform and to work across sectors at the community level to prevent disease in communities in the first place. We must make investments to address the root causes of poor health and inequity in neighborhoods where factors such as high levels of poverty, low educational attainment and unemployment lead to higher rates of illness and injury and life expectancies that are often over a decade shorter in certain communities in our state than others where citizens have more opportunities, or Californians have more opportunities and resources. As a nation, we spend nearly 1/5 of GDP on medical care costs. These are costs that sap our ability to invest in other critical areas like education, renewable energy, or infrastructure. But an investment of just $10 per person in proven community-based programs to increase physical activity, improve access to healthy food, prevent smoking and other tobacco use could save us more than $16 billion a year in the nation, a return of $5.60 for every $1 spent. A reduction of just 1% in common chronic conditions among the 2.6 million current members of CalPERS is projected to yield a savings of $3.6 million a year. And I want to share just two examples where California is leading the way at a community level to show innovation in this type of multi-sector approach. First, California's CDC-funded Community Transformation Grant, which unfortunately only has one more year to run in California, CA for Health, covers 42 counties and most of the state's rural population. It takes a multifaceted approach to address the risk factors that lead to higher rates of chronic disease in rural areas of our state, including reducing exposure to secondhand smoke, decreasing sugar consumption, increasing physical activity, and, importantly, promoting linkages with clinical care providers. This initiative, CA for Health, is proving that a coordinated effort in population-based chronic disease prevention in rural and small California counties can work to address the social determinants of health and reduce barriers to where states' resources have been limited. A second initiative is California's Health and All Policies Task Force, which is demonstrating true leadership from the state as well as community partners. With funding from the California Endowment, PHI provides staff support for the task force, which brings together representatives from 19 state agencies and departments, and has created several multi-agency work groups focused on aligning efforts around the goals of health, equity, and sustainability. Agencies participate voluntarily in this effort. The governor's budget includes a BCP to create new general fund-supported positions in CDPH. While we welcome this, we also need to do more to leverage the success to date and provide funding support in other agencies and departments, and critically at county and municipal governments to fully embed this approach. In closing, I must urge that any consideration of new funding and investment of resources for public health must reflect that no one sector alone can address these challenges. Already, the State Health Department, unfortunately, is beset by administrative barriers that limit their ability to work effectively with non-governmental organizations and communities. We must ensure that the state receives the support it needs, as well as new funding be tied to specific outcome measures that ensure funding is distributed and reaches communities available to county health departments, local education agencies, clinical providers, businesses, and critically, nonprofit and community-based organizations. Thank you.
Thank you. Bruce Palmer.
Madam Chair and members, Bruce Palmer with the Health Officers Association of California, representing the physician health officers in California's local jurisdictions. I want to thank you for having this hearing today. I think it's probably the most comprehensive hearing on a significant problem that we have in terms of maintaining public health services. What I want to talk to you briefly about today is a perspective from the health officer's view of what we do in the community. As physicians, they don't treat people. They treat a whole community. They come up with a community-wide approach to look at the problems, the outbreaks, the diseases. They take a team of expert scientific individuals, microbiologists, public health nurses, epidemiologists, to come up with an overall strategy for treating disease in the community. Now, there's no specific funding source for this particular important function, but yet it is strictly a public function. Nobody else does it. Nobody tracks the spread of disease. Nobody gets the 80 some odd diseases that are reported to the health officer. It's a public function that is as critical and as vital as police protection, public safety, fundamental parts of government. And because of historical and economic situations over time, the funding for this has been frayed, the ability to do the work, doing complete directly observed therapy for things like TB, testing specific populations of homeless individuals for tuberculosis, targeting high-risk groups with HIV to educate and control the spread of disease. We've seen 20 years ago, a bill was passed to eliminate the premarital blood test for syphilis. Now, because that was a disease that was nearly eradicated, now it's a major problem in the community. We see gonorrhea. We see a lot of things coming back. This basic part of civilization, which had, from the turn of the 20th century forward, has had more to do with improving and extending lifespans, has been pulled back and degraded over time. It's slower. That means it doesn't have as much resources to follow up, and that means more people get sick and more people die. Now, what's the history of this? One of the things you wanted me to do is provide a historical perspective. Well, I'm going to provide one that goes way back. And basically, prior to Prop 13, most of this stuff was funded at the local level. When Prop 13 passed, local government revenues went down dramatically. To replace those revenues, particularly in public health, the state used its surplus to fund public health. The purpose of that money was to go to public health, not indigent care. At that particular time, there was a little bit that went into indigent care, but the primary purpose, for years, locals submitted plans and budgets that described what they did in terms of basic food, water, and protection from communicable disease, the most fundamental service of civilization. When realignment came along in the early 90s, indigent care money was combined with public health money. And then when this recent take-back of realignment occurred, revenues occurred as a result of the Medicaid expansion. Part of the rationale was, well, you get a Medicaid expansion, counties, so you can afford to give part of this realignment money back. The problem was part of that money was also core public health. So there is no distinct source of money to control the spread of those some 80 different diseases. There's no categorical program. And so what I really encourage you to do, and I think this is a very good start in that process, is to take a look. We used to know how public health was funded at the local level 20 years ago. We had the plans and budgets. The state can't possibly have a disease control mechanism if it doesn't have a strong local government presence. And so, because that's where most of the work is done. Thank you.
Thank you. Okay, Rusty Selleck.
Yes, I've got a handout here. Thank you. Good afternoon. Rusty Seelix, California Council of Community Mental Health Agencies and Mental Health America of California. The Early Mental Health Initiative is a school-based prevention and early intervention program that existed in the state for about 20 years, targeting kindergarten through third grade youth at very high risk for developing serious mental health problems they did not yet have. They had mild to moderate problems. Since it was funded for about 20 years, there is a wealth of data on how effective it was. The best statements are two. One is it's about the only program in all of my years lobbying for mental health, more than 25 years, in which the Department of Finance regularly came before these hearings and acknowledged it pays for itself. It saved money. The Department of Mental Health said, we never see these kids again. They don't wind up in special education. They don't wind up in child welfare. They don't wind up in juvenile justice. They don't wind up dropping out of school. The point is these are kids at very high risk. This is the kind of program that we ought to be funding. In addition to budget cuts, however, this program needs a home. It used to be funded out of the State Department of Mental Health, even though it was part of Prop 98 through schools. That department no longer exists, and most of its activities went to the Department of Health Care Services. Mental health special education was transferred to the Department of Education as part of a realignment of that program. This is really a public health program in a classic sense of providing prevention and early intervention, of working with teachers in kindergarten through third grade to identify these very high-risk youth, and it worked. These kids were in the 10 to 25 percentile when they were identified, and it showed that 2 years later, after the services ended, they were still over the 30th percentile. So it worked, and frankly, it's one of the most cost-effective strategies we could possibly invest in. Thank you.
Thank you. Laura Thomas.
I'm Laura Thomas. I'm the Deputy State Director at California for the Drug Policy Alliance. And I wanted to say, first of all, thank you for holding this hearing, and thank you for looking at reinvestment in public health here in California. I'm going to talk about why we need to invest in our public health infrastructure, specifically to reduce deaths from drug overdose, including prescription opioid overdose deaths. I'm going to talk a little bit about the overdose problem, one effective response, and our budget request. Drug overdose is currently the #1 cause of accidental death in California and in the United States. In 2011, it surpassed motor vehicle deaths as the leading cause of accidental death here in this state. Motor vehicle deaths have dropped over the years because we've made important and appropriate investments in reducing the harms associated with motor vehicles, including highway design and airbags. In the meantime, overdose deaths have grown, driven in large part by the increase in prescription drug use and misuse. This year, there will be over 3,000 deaths here in California alone. That's 8 deaths a day, or 1 every 3 hours. And each of those deaths leaves a grieving family and friends. Prescription drug overdose death is a public health problem that requires public health investment to address. The investment that we are proposing is in naloxone programs, naloxone purchase and distribution. Naloxone, or Narcan, is a highly safe and effective generic medication used routinely by emergency personnel. It disrupts an opiate overdose and does nothing else. It is not a drug you can get high on. It has no other effects. It's very safe, and its broader distribution and use is supported by a wide variety of organizations, including the National Institute of Drug Abuse, the Office of National Drug Control Policy, the American Medical Association, and the American Public Health Association. The state of Massachusetts and North Carolina and the city and county of San Francisco are examples of very effective programs where public health investment has dramatically reduced overdose deaths. Our budget proposal is for $2 million over 3 years in grants to local health departments, local law enforcement organizations, and community-based organizations working with family members, at-risk people who use drugs, first responders, and law enforcement officers. My colleague, Dr. Davidson, is here, and he'll talk more under public comment about the potential results of that investment. Here in California, the legislature has worked to address some of the legislative and regulatory barriers to broader naloxone access, but funding remains a significant barrier. California can afford to invest in preventing these deaths, and I don't think that we can afford not to. Thank you.
Thank you very much. I want to thank our panel for presenting. We're going to ask our staff to come back now to see if they have any response to the proposals, the ideas that have been put forth. Then we'll hear from our legislators, and when we come to public comments, we're going to have to limit them to 1 minute each because of the line.
Squeeze through.
Okay. Any comments from the staff? LAL or staff? Yes. From
Sure,
Public Health.
Madam Chair, Dr. Ron Chapman, State Health Officer and Director of the Department. I believe we were asked to respond to 2 questions under this particular item. One regarding a history of general fund reduction since 2008 and the impact on services and how our department prioritizes public health issues. And I'd like to begin with responding to the first question with our Chief Deputy Director of Operations, Dan Kim. Thank you.